Welcome to Leipzig.
Okay, great. All right, thank you. Thank you so much for having us. I also want to thank my partner, Dr. John Runback, for allowing us to participate. And we have here with us Dr. Mish Patel, working the contralateral side, Donna Freitag, our technologist, and Jana Reichlen, our procedure nurse. So this case is a patient with a severe chronic venous disease, 71-year-old male with bilateral complex C6 chronic venous disease. Next slide. You can see the picture of his legs, severe erythema, pigmentation, and ulceration as well. Next slide. So in the process, he came to us initially with an abnormal arterial Doppler study. We worked that up with the CT angiogram and did not seem to have any critical inflow stenoses, no combined arterial venous insufficiency, but we did note severe venous insufficiency. Next slide. Both in the peripheral venous system, specifically the greater saphenous vein. And he underwent EVLT as well as ultrasound-guided sclerotherapy treatment in June of 2014. Subsequently, he was doing well, and then the wounds started to come back, and we put him in Uniboot compression therapy and multiple sharp debridement therapies, and was doing well. And that was just recently in December 2014. And now the plan is, after reviewing the case again, we noted that he really has severe axial venous reflux. And we've sort of got very interested in the pelvic pressures and stenting potential outflow stenoses to help with the reflux and to be able to treat these patients easily. So the plan is really for bilateral common femoral vein access. We're going to perform pelvic venography, intravascular ultrasound. We'll obtain pressure measurements and possible stenting as needed. So we're going to go ahead and to the live images that we have here. Right now we have bilateral 11 French sheaths in each common femoral vein. Actually, from the left side, we have a 035 Advantage glide wire up and over, which can sometimes be helpful identifying the venous confluence. And we're going to go ahead and perform bilateral pelvic venograms from both sheaths, and we're going to see what we have. Okay, hold your breath, don't move. Can you arm the injector? Okay. Okay, so we'll run through these images here.
Just notably, I'm sort of standing in the back here. We talked about the presence of collateral, so I have a harbinger of events here, so I think we're going to find some disease. But again, we can't even see those collaterals necessarily, which is interesting. I wonder if that's
Case, what do you think about that left side there?
Well, it looks perfect to me.
A little bit of reflux into the internal, but you're not seeing any collaterals?
No collaterals seen on that. We'll agree with that. So now we're going to go ahead and with the up and over access, I'm going to put the IVUS catheter in, and we're going to do a pullback. Usually we'll go from the IVC and down, but because we have the wire up and over and we're looking at both sides, I'm going to go from the right common femoral vein through the right external, internal iliac vein, and back to the left side and see what we find, if anything.
So, Peter, severe axial reflux, lower extremities, what will trigger investigation of the pelvis for you?
I mean, typically, if a patient has severe bilateral swelling and has at least some major segments of the lower extremity veins that are competent, that would concern me. If we have...
Is the patient awake?
Yes, he's awake. Again, conscious sedation. Are you seeing that, IVUS?
Yeah, if you could ask during the IVUS if the patient can put in a Valsalva maneuver, because that will dilate your veins nicely, and then you don't overestimate your disease.
All right. So when you go back to that,
sure, let's go back and try that.
Really to let them press hard and long.
Tell me when you're there. I'm going to ask you in a minute just to hold your breath and bear down like you're moving your bowels. I'll tell you when. Okay? Right? Okay. Right now, hold your breath and bear down like you're moving your bowels. Bear down hard, bear down hard, bear down hard, bear down hard, Bear down hard. Bear down. Bear down. Still compressed there, okay? Very, very narrow through that segment. All right, now you can relax. Okay. Okay. What did you guys think of that IVUS? It still seemed like there was an area in that external that looked compromised.
And now we're coming back through the left side.
Well, the problem with the ultrasound like you do it is because you have it bended, the wire itself is going to stretch the vein flat because you have tension on the wire, and that will always cause the vein to flatten because you just put it to the lateral side. So that's a little bit a disadvantage of using the IVUS in this direction. At least that's our feeling that we have if we do it like this. That's why we want to be sure we always open it up in the inferior vena cava to be sure that's without any compression or stretching of the vein, because the vein, you can make any diameter.
So let's do that right now. I'll pull back this wire. We have bilateral access, so that's not a problem at all. And if we want to treat that side, we can do that. So we're now going to go ahead and put the wire into the IVC.
Thank you.
And I'm going to go ahead and advance the IVUS right now into the IVC from the left side. Okay, so we're now in the IVC here. Okay, and the wire is up in the IVC, and I'm going to do my pullback right now.
One more time now. Bear down. Hold your breath and bear down. It still gets pretty compromised there. I mean,
we're now in the external iliac vein. Yeah. And I'm just about to get into the sheath now.
Right.
Okay.
So go up to that most stenotic segment, if you can just sort of put it there.
I'm going to go forward right now. Live, please.
So what do you guys sort of...
I think it looks fine. Right.
Well, this is the external iliac.
Think of this appearance here, where we're basically, with the wire up in the cava, you can see the lumen of that external iliac vein just below the internal iliac vein is basically the diameter of this OP5-based IVUS. So would you all agree that, interestingly, there's compression here? That's with Valsalva. Let's do the Valsalva again, staying right there. Right now, one more time. Hold your breath and bear down. Like moving your bowels. Hold your breath, bear down. Okay, relax. So that's with Valsalva. That doesn't change very much. All right. Would you do anything further? Would you do some hemodynamics? We have a ratty here.
Yeah, we're ratty, ready to go. If anybody
you can ask him to move his feet during looking at this.
Okay. Well, we squeeze his calf as well, right?
That's also.
Squeeze right here.
Squeeze hard.
All right, squeezing his left calf now with the IVUS catheter in the external iliac. It does squeezing.
If he can move himself, that would be better. If your calf is moving yourself, then
it's going to be difficult for him the way he's positioned and given all that ulceration.
Okay.
That's okay.
So, Gary, using IVUS in your...
We're going to set up for the ratty anyway. Let's just do that.
We do quite a bit because of this. And many of the shortcomings have been pointed out already. Because of, one, you see compression on a third of the people you do it on, even without symptoms. So you have to be very selective about who's really got a physiological problem. And we use some of the different veins that, before and after. We use the maneuvers. Sometimes we'll actually see it we'll put a big sheath in and actually inject around it to try to give all of a sudden a big fluid bolus to see if it'll stretch. Because really the patient, I think that, again, anecdotal, the ones that we've been most successful have a fixed obstruction. It's not stretchable. So if you have an IVUS there and you have a 60 cc syringe and you've got a 8 or 9 French sheath, and you give them a big.
We'll go ahead and do the ratty.
If it doesn't dilate, then you've got obstruction. Now I may be not sensitive enough doing that, but for right now, that's where we.
I agree with the idea of doing IVUS, and I like the suggestions of dynamic maneuvers mentioned by both panelists. Typically, we put the patient in a little head up, foot down position to also increase the pressure in the pelvis and lower extremities. But if I come away unsure, then I do what every good angioplasty doctor does and get out an angioplasty balloon and be very gentle, but I don't think there's a big disadvantage to checking to see if there's a waste on the angioplasty balloon. If I really come away unsure, rather than make the guy come back or have some possibility that I've missed something.
Yeah, I think that leads to another discussion where we have done that, got a great result with the angioplasty and stopped and not stented. I know that's heretical, but some patients with little focal lesions have done okay with that. So, Kevin, you doing a pressure wire there? Was that what you were doing?
Is the key. Yes, we did the pressure wire, and based on my understanding, there should be a change of 2 to 3 millimeters of mercury if there's a critical venous stenosis as part of high venous pressures. And in the IVC, we had a mean of 3, and right through the stenosis, we had a pressure of 6. So that was the increase of 2 to 3 millimeters of mercury, suggesting again that this external iliac vein stenosis may be contributing to this patient's
okay, so I'm going to go right to case
and severe disease.
Case.
So Kevin, how do you arrive at that 2 to 3? What's the basis for that?
No, we
that
don't,
is from
we
a
don't
paper
rely
that I
on
have,
pressure gradients.
been
I think
studying.
if we got, I think what we also do, if we think there is something out there, we put in a compliant balloon and see if we have a real stenosis, which we can visualize. And on the other hand, we always look at collaterals. If there are no collaterals, whatever our findings is, we do nothing. If there are collaterals, then we still want to know exactly where it is. And then a diagnostic ballooning is sometimes of help before we take the decision to stent it. But we never ever, if we treat something, we balloon as a treatment, we always leave a stent. We don't ever do only PTA and have a look at it and it looks nice, then we still put in a stent because the recoil in the long term in our hands is so big that we have learned our lessons that we always have to stent afterwards.
And this is really, it's really different than the upper extremity, right? Where the motion on the stent is so complex in the upper extremity where we
But
play
that's
at the
a
opposite.
big gradient.
Really want
Even without collaterals, I got to admit,
John,
that's
sorry.
a big gradient.
So,
If this was a
Gary, you're saying that's a good gradient, 3
I mean,
millimeters?
he had a 40 millimeter gradient. I mean, that's pretty darn big. I mean, if we had a
So we're passing the balloon now.
with that kind of gradient, we'd be putting a balloon in.
I mean, sort of convinced us in
this was
3
the
different
area
ways.
of
Right?
more
There's
critical
been imaging
stenosis.
that's been physiologic.
Yeah.
I mean, there's been 3 different ways of confirming that this is there, plus the historical.
feel a little pressure,
These are
sir.
dynamic compressions.
10 and 20?
Yeah.
Problem with this undersized balloon is it may not tell you.
No, that's it. You have to use a big.
You have to use a good sized balloon.
And in Ohio, that's not.
It was just a 10, but, I think my gut is here that we've proven this several ways, like Tony
I
just
agree.
said. And,
Oh, I think so too, John.
yeah. I think
Yeah.
we're ready to go ahead and just put the stent. And we tried the balloon, but, at 10 millimeters, these can be relatively compliant compressions and not much difficulty. You may not see a focal waste, so.
Okay. So we're
The
going to go
audience
ahead
said they would
and,
have stopped
I
after
think
the
we're gonna
first 2
use
things, so they could have fixed it and had a cup of coffee. Or,
We're with you, John.
Yeah, well,
Yeah, but
we're
I
trying
think
to
this
keep up
is a
with you guys.
great
You're running pretty fast.
discussion.
Yeah.
Kevin, you're doing a great job. You're getting a lot of input from the panel.
you.
And just doing a great job with this. But this is
Yes,
kind of how
no,
they
it's
work.
extremely,
These can be
extremely helpful.
tough
Thank
to
you,
figure out sometimes.
Yes, absolutely. And you have to look at and really know the patient as well, because this patient has severe venous disease and stasis. Now, the one tricky part, I think, of this case is going to be pulling back the sheath enough to stent low enough in the external iliac, almost up to the common femoral vein. So I'm going to mark that now.
So I believe this is a 16 millimeter wall stent, right?
Yes, we're going to be using a 16 millimeter wall stent.
Just to be able to measure everything.
1660 wall stent.
1660, yes.
So,
And I'm gonna
curious from the
pull
panel,
back.
stenting considerations in this area. This is an area where you can get some flexion. The stent of choice on the panel for this particular location. I know Case is going to have a different answer than everyone else, but Peter, what would you put here?
Do a
But
quick
what we would, we
run
probably
here.
would not, we would like not to put a wall stent if possible because of our difficulties. Like Case doesn't use them at all and he highlighted why, because you cannot tell where the distal end's going to land.
This is one that I might do from up and over. I mean, typically we don't do it that way, but in this case, I might consider putting it in from the right. If a wall stent was all I had, that's how I would do it.
You know, I like the characteristics of the stent. It's just the deployment difficulties, like you said.
May I ask you something? You didn't see anything on the other side? On
we
outflow
did, yes,
or problems?
We did. Yes, we absolutely did see a stenosis, a very similar stenosis on the IVUS.
On the other
right
side.
And I was gonna, on the right side, correct. I'm stenting the left now from the left, and I did have that wire up and over with the plan to stent with the up and over approach, as you guys had mentioned, but we did pull back just to sort of confirm the suggestion that some of the
wire bias.
The reason why I'm asking is also to keep the pathophysiology in our back. You have a symmetrical clinical picture on the lower legs, and if you find nothing on the one side and something,
no, it's
like
symmetric.
Okay, thank you.
It was the exact same disease.
So,
all right, so we're gonna
what's
now
the
pull back
etiology of this one?
That's interesting. You know, on the IVUS, there was an artery kind of near it, and kind of not immediately at the level of greatest compression, but above and below this artery did seem to be against it, and actually you could almost see some pulsatility in the vein. So, you know, particularly as people get older, we know that they get ectasia in the iliac vessels, and I think that contributes to it. That, you know, combined with, you know, maybe some underlying atherosclerosis and sort of chronic kind of fibrotic and inflammatory changes. So we don't know for sure, but clearly on IVUS there was proximity of the artery to the vein in this case.
Maybe, what do we have, a 16 balloon?
I think it's a good point. You know, we talk about May-Turner, but that's just one of many compressive syndromes. You know, as Gary said earlier, May-Turner was described classically on the left side, but you can get compressive syndromes on the right side. You can get compressive syndromes in the external iliac. So
before doing that, just give me the inner portion. I just want to get back into the...
So this is, I got to give Dr. Herman credit for trying to do this from this side. I think I would have come up and over too. So
yeah.
He's close there to the puncture. He's going to pull this back and get the sheath back in, and it looks like it's fully expanded so that we didn't get caught up in the venotomy.
That's right.
Oh. Gary, how low?
So it looks pretty
do you
good.
feel comfortable?
Looks
It looks
good,
great. Yeah, no. Gary, how low are you comfortable bringing stents?
To confirm.
And John, I'm thinking maybe he's got the other side to do, but maybe if this IVUS looks good, you guys want to do another presentation, and we have, I believe, until 9:30 our time. We have a preloaded prior PE case, so if we have time, maybe we can sort of get through that.
May feel a little pressure, sir.
Yeah, I think that'll be great. What we'll do as soon as we see this IVUS, then we'll go to the next presentation, then come back to you, and we'll have about 10 minutes.
Perfect. Yeah, I know there's a lot of interest in PE.
We'll take that down. I'm just going to balloon the lower portion just slightly. We'll have the IVUS ready to go.
So I think, as you said at the introduction, I mean, we're really now appreciating the full spectrum of venous disease. And I think this, we saw two interesting cases. First of all, the chronic DVT, which is an entirely new approach to a very common and debilitating problem. And this idea of these pelvic venous compressive syndromes, I mean, you know, classically, we would see several patients a year who were presumed to have lymphedema, who would be found to have some pelvic venous compression. But, you know, very often, even when we evaluated those patients, we didn't appreciate the nature and the frequency of these sort of compressive phenomena. Again, this is sort of a bit of a game changer. You know, the data bears out that these patients who have axial venous insufficiency maybe have frequent underlying, you know, compressive pelvic venous syndromes. That would be pretty dramatic. You know, it's a whole cohort of individuals who we otherwise didn't have a whole lot to offer.
So, John, I think we're going to leave you now. I'm going to go. We have one more quick talk, and then we'll be back. Otherwise, we're going to run out of time, and we won't get to see your PE case. So.
All right, well, give us 10 seconds, John. Here's the IVUS coming up right now.
There you go.
Boom. There it is.
And there's a stent fully well deposited.
Yeah.
And we may have to stent a little bit higher if we will run through that again. But it looks pretty good.
Yeah.
We'll do a pullback now.
All right.
And here's that external fully flush now.
Good. So we'll see you back after the presentation.
Good, yeah.
We'll talk
and you'll
about
have about
PE.
5 minutes when we come back to you.
Thank you, guys.